Hi all, welcome back to Emergency Medicine Lecture Series. In the current video, we are going to discuss how a pediatric patient differs from adult patient in terms of anatomy and the physiological variations and their implications for an emergency physician. I'm Dr S Prakash Babu, Associate Professor and HOD, Department of Emergency Medicine, St. Peter's Medical College Hospital and Research Institute, Hosur. So what is the importance? Why should you know the differences between pediatrics and the adults? You know that children are small, but children are not small adults. Even though their organ systems are completely developed, they cannot be considered as small adults. We'll see why they cannot be considered as small adults as we go further. There are anatomical and physiological differences between adults and pediatrics, which implicates in their assessment, management, and also treatment. They have smaller airways, they have faster respiratory rates, and there are distinct cardiovascular responses either to stress, normal physiological changes, or when there is a trauma. Ongoing development impacts the drug dosages, the fluid management, and trauma responses. So you will have to have a precise understanding so as to enable you to accurately assess, identify the patients early who are sick to perform appropriate interventions and to improve the outcomes in pediatric emergency department. Coming to the epidemiology, I don't have an exact data for the Indian scenario, but more or less it might be equal to the US scenario. In the US, 20% of emergency visits are for children. Even though there are freestanding pediatric emergency medicine departments in most centers, almost 80% of centers, emergency departments cater for both adults and pediatrics. 20% children will have at least one emergency visit per year. Age group with the highest emergency department visits per capita. When you compare with the total number of people available and their emergency usage, infants account for the maximum number of per capita emergency medicine department usage. Is 85.5% per 100, where it is about 1 per 100 or 1 per 1000 in adult patients. More than 80% of pediatric patients are seen in general emergency departments, as I told earlier. So let's focus first on the key differences and how they influence emergency physician in decision making. The first and foremost is, you know, they are smaller in size and they are rapidly undergoing growth. When it comes to adults, their body mass is larger and the growth rate usually slows down. How does it impact? It impacts in equipment selection, selecting medication doses, and assessment of milestones need to be adjusted for the physiological variations. The respiratory system, the airways are narrower, so there are faster respiratory rates to compensate for the minute volumes they need. Adults have wider airways and the respiratory rate slows down. Hence, these pediatric patients are more susceptible to airway obstruction because of narrower airways, and there is easily go into respiratory distress because already they are having faster rates. If the rate increases further, there is going to be a stress on the system, and they will rapidly desaturate because the only parameter that they can alter in the respiratory system is the rate for accommodating the increased minute volume. Coming to the cardiovascular system, again they have higher heart rates, but the blood pressure is lower. So the main difference between compensating between adults and children is children usually compensate for hemodynamic changes by heart rate, by increasing the heart rate, whereas adults usually compensate by increasing both the heart rate and also the force of contraction of the heart to eject more blood. So when it comes to vital sign interpretation and the assessment of shock states that need to be adjusted for the pediatric patients. The gastrointestinal system, they have immature digestive systems. In adults, The digestive system is usually more mature. So pediatrics usually have increased risk of dehydration and electrolyte imbalances because their absorptive capacity is less and they have very narrow range of maintenance of electrolytes, especially in case of vomiting and diarrhea. Neurological system, there's ongoing brain development and they cannot easily compensate for the changes neurologically. Adults' brain development is complete and they can compensate over wide variation of physiological changes. So when it comes to responses to traumatic brain injuries and seizures, children are more susceptible because their ongoing development and less neurological accumulation capacity. Coming to the immune system, they have immature immune systems. Adult immune systems are mature and they can launch a full-fledged attack on the invading organisms. So pediatrics are generally increased vulnerability to infections. Temperature regulation. Usually their subcutaneous fat is not well developed. So they struggle to regulate body temperature. Because of well-developed subcutaneous fat in adults, they can insulate temperatures and they can alter over a wide variation of environmental temperatures. So these pediatric patients are susceptible to hypothermia and also hyperthermia very easily. When it comes to fluid and electrolyte balances, pediatrics have higher water content per mass of tissue and there are more frequent fluid shifts. Adults have lesser water content compared to pediatrics and the fluid shifts are less vigorous. Hence, they can accommodate for wide changes in fluid and electrolyte balances. Pediatric patients usually go into dehydration very easily and electrolyte imbalances occur more frequently. When it comes to consideration of medication doses, weight-based and age-appropriate medication doses have to be used. But in adults, the standardized medication doses that you give. Communication and psychological factors. You need to have an age-appropriate communication systems, mostly involving the parents. Usually, most of the pediatric age group, especially the infants and the toddlers, will not be able to convey their symptoms to the doctor. So there is a communication gap which should be built by taking parents' accounts into account. You can easily communicate with adults. They can convey you their psychological factors, how they are feeling about their illness, everything, and you can discuss with them. Coming to the skeletal system, pediatric patients have softer and more flexible bones. Adults have harder and less flexible bones. Because of the softer and more flexible bones, pediatric are usually prone for green stick fractures without actually breaking both the cortex. One cortex is broken and the other cortex just melts. So the injury patterns differ between pediatrics and adults, also the fracture types. So careful handling and assessment is needed. As we already discussed, skin and thermoregulation. Pediatric patients have larger body surface relative to their weight or height. Adults have smaller body surface area relative to weight. Because of this larger body surface area which gets exposed to the environment, they lose heat or gain heat depending on the environmental temperatures very easily. Heat loss and fluid requirements are affected. Skin assessment is important in identifying dehydration and infections in children. Psychological response, they may react differently to stress and pain, may react similarly to stress and pain. Children may react differently to stress and pain, which can affect their behavior and cooperation during assessment and procedures. So you need to take that into account and you should have a plan how you are going to assess when you are not able to do normally. Let's have a look at the pathophysiology, how the pathophysiology in children differs from that of adults. Children exhibit distinct patterns of illness and injury. These patterns vary not only between pediatric and adult patients, but also among different age groups in the pediatrics because they are growing very fast. Understanding these differences helps emergency providers assess and treat patients effectively across all ages. They might be harboring an undiagnosed congenital anomaly upon presentation that needs to be taken into account. Drug dosing and medication choices depend on the size and the physiological factors. Vital sign normal ranges vary depending on the age. Persistently abnormal vital signs should not be overlooked and need repeated assessments. Temperature regulation, as we have already discussed, they have a high surface area to mass ratio to lose heat to environment more rapidly. Instability in temperature can impose high metabolic demands because most of the metabolic work is done in regulating the temperature. Neutral thermal environment should always be maintained when you're dealing with a pediatric patient. They should be kept covered between examinations to prevent inadvertent heat loss. Radiant warmers for younger children and overhead heating lights for elder children can help conserve temperature. As an emergency physician, you're going to focus mainly on the airway differences. This is the one which affects you mostly. As per the studies, an emergency physician working in an adult emergency department will intubate by the time they complete their residency, that is 3 years of residency program. They have intubated some 60 to 80 adult patients, but pediatric intubations are less frequent. Even though the volume is high, intubations are usually less frequent. Most of the residents, by the end of their training period, they would have performed at least only minimal number of pediatric intubations. The figure is around 5 to 8, but minimal number of intubations required as per the studies to foolproof intubate a patient is about 30. So the training is lacking. Coming to the airway differences, children have smaller airways and the larynx is also small. Adults have larger airways and the larynx is very big. You can see the differences in the pictures. The larynx is small, in adults larynx is big. The shape of the airway is more curved in pediatrics. It is more straight in adults. Muscle tone, they have flabby muscles because the neurological system is not well developed. Adults have more muscle tone in the airways. Epiglottis is usually larger, flappy, and omega shaped in children. In adults, it is generally smaller and more rigid and can be easily manipulated. Whenever performing an intubation or direct laryngoscopy, in pediatrics, you are supposed to include the epiglottis into the blade, whereas in adults, you are going to put the tip of the blade at the base of the epiglottis and lift it up to expose the vocal cords. When it comes to the larynx shape, it's usually higher and more anteriorly placed. You know, if the larynx is higher and more anteriorly placed, it will be difficult to do a direct laryngoscopy to visualize the vocal cords. In adults, it is lower and more posterior. It would be most of the time easily visualized. Cricoid cartilage is the narrowest point of the airway in children. In adults, is the widest point of the airway. The narrowest part in adults is the glottic region. Once you cross the glottic region, your tube is going to go into the trachea. But in pediatrics, subglottic region is the narrowest part, of the cricoid cartilage zone is the narrowest part. Even if tip of the tube has entered into the epiglottis, the glottis, still you have chances of the tube getting dislodged and going into the esophagus. Trachea is shorter in pediatrics, it is longer in adults. And the tracheal rings are well developed in adults, causing trachea to stand up. What are the implications? Some of the points as I have already discussed. Large tongues in infants and young children can obstruct the airways during seizures and altered mental status. And their smaller airways, they are prone for airway obstruction very easily and desaturate very quickly because of lower reserves. And the only compensatory mechanism to increase the minute ventilation is the respiratory rate, which is already at the border higher levels. Nasopharyngeal airways can help to bypass obstruction caused by large tongues because nasopharyngeal airways are flexible. They can be easily placed and they won't cause any injury during a seizure or patients with altered mental status where intubation is either postponed or contemplated at a later time. Children with small airways are prone to blockage by secretions, so frequent suctioning of the oropharyngeal secretions is essential. Infants primarily breathe through their noses, making them susceptible to respiratory distress from nasal secretions. Airway suctioning reduces an infant's work of breathing significantly because they have to push air through the trachea. They don't have to fight with the obstruction by the secretions. They have large occipits, and large occiput causes neck flexion, and there is potential airway obstruction. This can be overcome by placing a roll under the shoulders, which reduces the respiratory distress and enhances intubation conditions. Coming to the cardiovascular implications, some of them I have already discussed. Mainly the compensator mechanisms. Children usually maintain blood pressure when the cardiac output is decreasing by increasing the heart rate mainly. Whereas in adults, it's both increase in heart rate and the increase in the force of contraction of the heart. Heart rate regulation, they can significantly increase the heart rate to compensate for decreased cardiac output, making tachycardia an early sign of cardiovascular compromise. Blood volume and vessel compliance, because of ill-developed neurological system, children have proportionally higher blood volume and more compliant vessels, potentially masking signs of shock until later stages. Coming to the myocardial reserve, they have greater myocardial reserve, allowing them to handle increased heart rate and stress during critical situations. Oxygen consumption, they have usually higher basal metabolic rates and they need more oxygen, making them more susceptible to rapid deterioration during illness. They have also less reserves, which desaturates them faster. Heart position, children hearts are more horizontal, potentially affecting the point of maximal impulse location during assessment. Blood pressure regulation, blood pressure norms vary by age. Age-specific reference ranges are necessary to detect abnormal blood pressure levels. Bradycardia is usually a late sign, which indicates impending cardiac arrest and should be treated as an ominous sign. They can vasoconstrict peripherally to maintain blood flow, contributing to delayed signs of shock. But this vasoconstriction is not as pronounced as in adults. Children respond more quickly to fluid resuscitation. So transient response is very high rates. Baroreceptor reflex. Pediatric patients have more sensitive baroreceptor reflex, leading to rapid heart rate changes in response to hypovolemia. Venous access and drug administration. Size appropriate venous access and medication dosing are crucial for effective treatment. Coming to the respiratory differences and their implications. Larger and more rigid airways in adults, narrower and more collapsible airways in children, more prone to airway obstruction, especially during swelling or secretions or seizures, altered mental states. Respiratory rate is faster. They can easily go into respiratory distress. Breathing pattern, increased work of breathing in children during distress can be easily noticed. Alveolar surface area is smaller, so faster gas exchange, increased vulnerable to respiratory distress, and lowered respiratory reserve. Oxygen consumption is lower metabolic rate in children. Children can experience rapid desaturation during periods of increased oxygen demand. Chest wall compliance is greater in children. Increased risk of barotrauma and chest injuries in children due to greater compliance. Chest wall shape, rib fractures are less common because their bones are very flexible, but more significant in children. If the rib is fractured in children, you need to suspect or a confirmed underlying lung injury because the chest is so pliable, it can go in and come out, causing lung injury without any bone fractures. If you notice a rib fracture, there is a more serious injury, most commonly crush injury. Lung reserves are larger in children, have limited ability to compensate during respiratory distress. Diaphragmatic constribution, diaphragmatic fatigue is more likely in children during severe respiratory distress. Pharyngeal tissue is more collapsible, increased risk of airway obstruction during sedation or loss of muscle tone. Minute ventilation is higher, children require higher minute ventilation per kilogram body weight. Respiratory distress signs, clear signs of distress in children aid in early recognition of respiratory compromise. Usual signs of respiratory compromise include grunting and retraction, subcrustal and intercrustal retractions. Again, they respond differently to trauma. They have smaller and rapidly growing bodies, different injury patterns, and potential for hidden injuries. Risk of airway compromise and specialized management in a pediatric trauma patient. Delayed onset of shock, need for early intervention. Rapid development of shock, quick intervention is needed. Pain perception is altered, and even the communication regarding the pain is altered. Adequate pain management and careful assessment is required. Different fracture patterns and cautious handling of the softer and more flexible bones is required. Brain development. Brain is developing and more vulnerable, risk of brain injury. Careful monitoring and treatment is required. Metabolic demand is higher. Quick response to injuries, nutritional considerations. Communication, limited verbal skills and emotional reactions. Age appropriate communication involving the parents is crucial. Healing response, because they have higher metabolic rates and the rapid growth. Usually, recovery is quick, but potential for abnormal scarring is there. So you need to be very careful. Coming to the differences in the immune system, children's immune system is still developing, making them more susceptible to infections requiring different vaccine schedules. Maternal antibodies usually provide protection in the initial months, but they wane over time, 3 to 6 months, leaving children vulnerable to certain infections. The thymus, critical for T cell development, is more active in children, leading to greater T cell diversity and responsiveness. Their innate immune responses might not be as strong as adults. It affects their ability to quickly fight off infections, more susceptible for infections and sepsis. Children might generate robust antibody responses, but they may also exhibit higher susceptibility to certain pathogens due to immaturity. Children often require multiple doses of vaccines to achieve optimal immunity due to their developing immune systems. Children might have lower risk of autoimmune diseases due to their immunological immaturity, but they can develop allergies more easily. Children's immune memory might be less established, leading to a higher likelihood of recurrent infections after initial exposure. Developmental milestones and what are the implications as an emergency physician? The infancy, they have limited communication, rely on nonverbal cues and observation, risk of accidental injuries due to lack of motor control, rapid changes in vital signs and response to illness or injury or also treatment. Toddlers have limited verbal communication again. Usually they fear strangers, especially the doctors. Assess using visual cues and gestures. Increase the risk of falls and traumatic injuries because they are very active. Fear of strangers and unfamiliar environments during emergencies affects effective evaluation and communication. Preschool children, their vocabulary is expanding and they might be able to describe symptoms more precisely. Curiosity and risk-taking behaviors leads them to more prone for injuries. Awareness of pain and anxiety, approach with gentle communication is essential for preschool children. For school-age children, the communication skills are improved. They can express symptoms and their concerns. Active participation in sports increasing the risk of sport-related injuries. Beginning to understand cause and effect relationships in health. Adolescents, they have advanced communication skills, able to provide detailed medical history. Again, they have risk-taking behaviors and experimentation leading to accidents. Mental health considerations become more prominent. Special needs children should have an individualized care plans and communication methods, recognize potential sensory activities or challenges. To conclude this topic, unit anatomical and physiological features that influence their responses to medical interventions differentiate pediatric patients from the adult patients. Need to understand these differences to deliver an effective emergency care. From temperature regulation and airway anatomy to cardiovascular physiology and immune function, each aspect plays a vital role in the pathophysiology assessment and treatment strategies. Early recognition of age-specific signs of distress and tailored approaches to communication contribute to optimal care delivery. By acknowledging the intricate interplay between pediatric anatomy, physiology, and the art of emergency medicine, we ensure the best possible outcomes for young patients. Thank you. Success is not final, failure is not fatal. It is the courage to continue that counts, said by the great Winston Churchill. Thank you once again. Do not forget to share and subscribe the videos.